So welcome to week 9. You have 3 more weeks and we're done, and then it's Christmas. I mean, blink your eyes and we're going to be done. Next week we have our first exam, an exam, of course, exam 3. I'm doing my review tomorrow at 5 o'clock, and I've posted all of them in the announcements. They started today, tomorrow, Thursday, Friday, and Saturday morning. So if you want to go to them, Unistay loves to go to the live reviews. Did you go to the one this morning or this afternoon? No, this evening it was. No, you were in community. You couldn't.
Yeah, we had exam on community, the last
Okay.
exam.
Well, I will be posting that recording as soon as Professor Corfor gives it to me. So, I'm pretty quick with posting stuff. If I get it, you have it too, because I know that, you are going to be looking through it. Next week after the exam, I'm going to do a HESI review. It's not going to be a week 10 something. I mean, week 10, if we talk about it, there's stuff about dermatology, there's stuff about death and dying, but we incorporate all of that stuff so much within the course that I think that you all will benefit from one of my Kahoot HESI reviews. So I actually have 2 of them. One of them, which is longer, one of them that's shorter, and that's the one I'm going to give you, so that you're going to be able to get these concepts and repeat them so that you'll be okay with them. So that's what I'm going to do next week for you. So I want to thank you. I mean, I literally got all but one pediatric assessment assignment. And most of them were great. Now, if your score is not 90 or above, go back and look at the comments I put you. If you turned it in by Sunday and you want to increase your grade, I will go back and regrade it if you do what I tell you to do. Okay? There was things like no references on the teaching PowerPoint, pamphlet, or picture board. There was also the teaching was not in the format that I asked for. I said, just put it there. It's great teaching. Just put it there. Or you could do this. I give you examples what to do. Just send it back and I will go back and regrade, because I think that as an associate degree nurse, you're learning APA. You're learning how to do projects. And I know many of you, especially in Miami, you're going to be going back for your BSN, because that's what Baptist Health System looks for. And that's the biggest paid hospital in the area. So I know some of you will be doing it. So I'm getting you prepared by showing you what you did wrong. So, or not wrong, but what you could improve upon. Okay. So this week, there's not much due. Now, there is a Kaplan due, but I'm going to warn you, I'm not going to look at it this week. So you actually have through, not this Sunday, next Sunday to get it in. So don't go crazy trying to get it in. Study for your exams. What you need to do is just a discussion question, okay? So this week is going to be easier on you. You're going to have time to take a breath, focus maybe on community, something you need to do, or med-surg you need to catch up on. So this is your breathing week. So just get discussions in. Anything that anybody needs, or if you've been late or delayed, please send me a message, okay? Let me know what's going on. I know some students in other classes had COVID, and were sick and couldn't move. I mean, tell me, just send me a quick message. And I know how hard when you're sick it is to get up out of bed, to even go to a computer or go to the phone and send a message, because when I get sick, I can't even lift my head up. So I understand, but giving me communication, I'll work with you. So please, if your grades aren't where you want them to be on that assessment assignment, you'll have till Sunday. After Sunday, I cannot do anything. It's closed, okay? So you want an improvement? Go for it. All right, we're going to be doing neuromuscular and skeletal muscular dysfunction this class. It's only like a 39 slide Kahoot. So I'm hitting all those key concepts that you do need. So let's start off with our PowerPoint. I think there's like 70 slides or something. Actually, they're 84. There's a lot of different concepts in here, but I'm going to get them so that we can understand them together. So musculoskeletal, this has to do with muscles, tendons, ligaments, and your bones, okay? So anything that does with that, you can see that there's traction on the bottom. That's called a buttocks traction, or crutches. It could be casts. And that little baby up there is in what we call a Pavlik harness. And that's when the hips don't go in the socket. They're sort of up a little bit, but we're going to go into that a lot more. Now, when we talk about musculoskeletal, we talk about sometimes they can't get out of bed for whatever reason. It could be something congenital. There's something called osteogenesis imperfecta, where just touching these, they have brittle bones. These children, they break bones quickly, and they have multiple breaks at one time. I've only seen one child with it, but I was so afraid just to lift them up to change a diaper, and you're just so careful with these children. Degenerative disorders. What about children that have these neuromuscular things like Guillain-Barré? What about things like Duchenne muscular dystrophy? And it's progressively you're unable to move. Now, if you've had some sort of infection or injury, you have a crushed pelvis, you can't get up, you can't move, this makes a child immobile. They can't move. They're stuck in bed. And remember, we need to keep those muscles moving because we don't want muscle atrophy. Besides that, keeping them from getting the atrophy and the joints stiff, get those joints moving, we want to make sure that there's no issues with the heart beating and unable to get the fluid around and become dependent edema and pulmonary embolyses and all of those things due to venous stasis. So, these are a lot of things that can happen to the child. Besides, they're alone in the bed all day. For how long? A month? And some kids are. Remember, these children are, number one, they're upset, they're angry, they even get aggressive, especially the older children, when, their parents can't be there 24 hours a day if those kids are there for a month, right? They're there for a month, parents do have to work. So these children are getting to the point they're tired of TV, they've already played cards, did their schoolwork if they have it, etc., but they're getting upset. So remember and identify that with that child. Say, I know it's hard to be alone. What can I do for you today? Something, I'm going to bring in my computer and I am going to work here with you. Okay, so that you're not alone. And sometimes just doing that can help these children. So we know if a kid is immobilized, like I said, parents have to work. Siblings are worried about their brother or sister, right? So many times what I'll do is I'll have these children that are immobilized this long. I'll be sitting with them, doing my computer work, whatever. I'll give them a piece of paper, some crayons, write a card to your brother, write a card to your sister, tell them you miss them. Or if it's a girl at home and it's a girl in the hospital, and I do bows for the hairs and whatnot, let's send home your sister a bow. These kids really appreciate it. Now, in many types of children and diagnoses, especially the hospital where I was at, there's a neuro floor, there's a cardiac floor, there's a newborn ICU floor. Parents have individual group meetings once a month and they share their feelings, share different things that maybe this family knew how to get this for their home care, that they're going to need home care, whatever. And it really helps that say, hey, they're feeling just like I feel, because it's very hard to have a kid in the hospital, can't be there all the time, and you don't feel adequate as a parent for the child in the hospital, the children at home. So it's very important. And then, of course, individual counseling if they need it. Now, traumatic injuries, kids, they're always doing something, right? Well, on Tuesday, Christian comes running to me. He made a fort out of the pillows in the living room. And he was crawling really fast underneath. And he hit one of my dining room chairs, which was part of his fort. And on his eyebrows, a 2-inch laceration. Comes running, Nana. Blood, of course, because the head bleeds a lot. And this big gaping wound. So it happens. Also, he fell down off a bike. You get these ecchymotic areas, et cetera, et cetera. Children is just what they do. they do have injuries because they're extremely competitive, especially when you're talking about going into sports. Now, a contusion is just a black and blue, but remember that black and blue is blood collection, squeezing the underlying tissues, which could occlude a blood flow. So always be checking your neurovascular signs. Check if it's on the thigh, check the toes, check the dorsalis pedis, the posterior tibial, check the capillary refills, because it could impede circulation. Especially when we get into the fractures that it comes up, always check neurovascular signs. And if it's a crush injury, you don't really know the extent of the internal problems that's going to go on. Now, children do get dislocations. I think the biggest one that I've seen is your toddlers, where you're swinging them by the arms and all of a sudden their elbow comes out of joint. And now that arm hangs to the side. It's called a nursemaid elbow. And all we do is take it, the doctor twists it, and the tendons are so flexible and malleable that it pops out. So we put it back in, put them in an arm sling, and tell the parents, it's not a good idea to do that anymore. And that kid is happy because now the pain is gone and they can move their arm more. Down's children, they're really hypotonic, right? They are so flexible. I've seen them put both legs behind their heads. Be careful with that. Their hips can pop out of joint. So I wouldn't encourage it, because if the hips pop out, then there could disrupt the blood supply and it could cause really, really bad problems in the future. Strains, sprains. Well, I think of all of these, sprains I've had the most. I was that sports kid in high school and in college. I remember going up, spiking a ball in volleyball, coming down on my ankle, and the whole ankle swollen and ecchymotic and swollen instantly, and it hurts. So we know after I did the first couple, and I'm telling you a couple, because I was, in sports for many years, I felt myself get a sprain, my leg would go right up in the air, because I knew that would help drain that extra fluid that's in there. We know rice is what we do, right? We're going to raise it, we're going to rest it, we're going to ice it, we're going to put an ACE bandage on it, and we're going to elevate it. And that's what's going to help it get better. Years ago, they didn't put casts or splints on sprains, but bad sprains today they are. They're putting them on there. At least they're going to put some sort of splint there, because it helps stop the movement, and actually it will heal better and easier. Strains is when you do something over and over and over again. It could be like shin splints. It's like you did something and you can feel the strain. It's not a sprain, but your muscle is in pain. And of course, again, that's also, we're going to rice it. We're going to rest it, ice it, put a compression bandage, elevate it, and immobilize it somehow, okay? Now, the other things, common kids, they fall down, right? So far, Christian hasn't gotten a broken bone, but I'm waiting for it. It's going to happen. He's fell off, he's bumped his head with a big ecchymotic area. Now he's busted open the same side of the eye, and, with this suture line there. But he didn't fracture anything yet. Now, the thing with fractures, we know it happens. If they fall, usually they put their hands out, right? They're protecting their heads. It's a natural response. Hands come out. So wrists are the most common. When the hoverboards came out several years back, and it was right around Christmas time, we saw many children with bilateral fractured radius and ulnars, both sides. So they got cast on both sides because they didn't wear any wrist protectors. So then they realized, well, maybe we should have some wrist protectors. Now, infants. Infants are very soft. They're malleable. It is difficult to break a bone on an infant. If you see a break in an infant, think, let's check the whole body. Now, what do I mean by that? Well, I had a little infant come in, had a little ecchymotic area behind the ear, and when I touched it to pick it up, to weigh it, it cried and it sort of smushed. I knew it was a fractured skull. just new. So I told the doctor, and we did what we call a bodygram. Take the x-ray, which is pretty big, right? Put the whole kid on it and do the whole body with one x-ray. This kid was 3 months old. Fractured humerus, fractured ribs, fractured femur, fractured skull. This child, our goal at this point, of course, we want to alleviate the pain, we want to do whatever medical treatment, but number one, keep this kid safe. So what do we do? Well, of course, the head doctor was notified, the supervisor. We had to call police and DCFN because this was not a normal thing. This infant, this 3-month-old, had a twin. We called the twin in, same injuries. They had a 2-year-old boy, was walking around on a fractured femur. So I want to tell you today, these children are safe. The perpetrator who did this is in jail for child abuse because it was that severe. But your goal, and let me tell you, being that nurse, dealing with these children, it was difficult. You want to punch someone. The mother brought them in and had no idea. It was the father, believe it or not. So don't go try to blame. Don't get angry. Just remember, I just need to protect the child, okay? I tell you that story because you'll see stuff like that if you work in pediatrics and your goal is take care of the kid. So there's different sort of fractures. The simple, which is a normal crack, the open or compound is when it comes through the skin. Now remember, when it goes through the skin, it's hit the environment and it's now infected, no matter what, okay? So this sort of fracture is more complicated, the open or compound, and will require IV antibiotics. And this child, usually put a cast wherever it is, but a window to look where that wound is so you can do wound care. You have complicated where maybe the ribs fractured and punctured a lung, or comminuted where there's little bits and pieces, and sometimes that requires an open surgery and fix it. Now, children are growing, right? They grow from what we call the epiphyseal plate or the growth plate in the bones. And these pictures down here show you can see where that growth plate is on that bone. The thing, if they get it, and it's usually an elbow, to tell you the truth, that's the most common place I've seen it. Usually when they do this, they will do surgery. It's an open reduction, internal fixation. They put plates and screws. They want it to line up and be perfect. Why? If they don't, you're going to have a shorter arm or shorter leg or a crooked arm or a crooked leg. So we want to keep it in good alignment, and that's why. Now look how quick neonates heal, 2 to 3 weeks. So for somebody to have had that child who with a fractured skull, I mean, that had just happened not too long ago, right? We know that putting cast on the infants, we don't have to put them on long. And then usually our kids, 4 weeks, 6 weeks max, they're out of their casts. I mean, when it happens right as summer break hits, they're like, oh, but no, I can't go to swimming camp. I'm like, well, about 4 weeks, we'll take the cast off. And then, you know, if your mother lets you, you can go. But as you get older, your bones are more calcified. They're not as malleable. Your healing isn't as good. It takes longer and longer and longer. So what do we do when we see a fracture? Excuse me. First of all, you look at the arm, the leg, wherever. You'll see swelling. You'll see pain, discomfort. You know, maybe they can't move their hand as well, depending on where it's at. And then you do a history. Yes, of course, the parents are going to tell you what the kid did. I try to ask the kid alone to see if the stories mesh. Only because, not because I'm thinking these parents are horrible parents. No. What is my goal? Protect the child, right? So just to be sure, and I make fun with it. I'm like, you were on that monkey bar and you fell off. That must have been scary. Tell me what happened. You hand slipped what? Because no, I was up there and la, la, la. Okay, stories match. Okay, I'm happy. The kid's all right. let's put that cast on. So we put him in a cast, it just gets it immobilized, and then of course it prevents that deformity, which is what we want. Now, cast is on. What do we need to teach parents, and what do we as nurses need to look for? Well, we send these children home with like a bag to put on so they don't get it wet, because a wet cast needs to be changed as soon as possible. It's actually very dangerous to keep a wet cast. South Florida, kids go home, put on bathing suits and jumps in swimming pools. And I saw one kid do it 2 times. Until I said, what do I have to do to you for you not to jump in the pool? Your poor mother has been back to this ER 3 times now. Please don't jump in that pool again. Anyway, we look for pain. Pain that's like getting worse. You usually see, like, if it's a cast on the arm, the fingers will get pale. This is your capillary refill. There is none, okay? Pulselessness, blood flow, if you can feel a pulse. If it's getting numb, if you see that paresthesia, and then paralysis. If you can't move it, something's going on. And of course, that pressure is part of that swelling. Now, this arm is like to the extreme, but it could happen if we don't monitor those casts really, really closely. So we need to know to look, but so does the child, and so does the parent. Now, in pediatrics, the pediatric hospital and where I live has all different color casts. If you go to another hospital system, no, you get a white cast. So isn't it more fun for a kid to get something in color? And we have pediatric orthopedic techs that know how to work with children and work with them well. I mean, look at that doll. That doll is the same colors as the cast as that little girl's in. Many times they'll do the color of their sports team, whether it is football, basketball, doesn't matter. They can do colors and combinations of colors, and then it makes it more fun, right? And again, remembering to have it elevated, to put some ice on it when they get home, to keep those fingers or the toes moving wherever that cast is, and then to follow up with orthopedics as they say to do. And nothing inside a cast. They put like hangers and stuff to itch. It can cause abrasions and could cause a bad infection. And then you're into osteomyelitis. You don't want that. Now, sometimes a cast don't work. You need to put them in some sort of traction. Now, one of the ones that I used, even in an emergency room, was a fractured femur. A fractured femur, the edges are all sharp and they get dislodged and they stick in the muscles and they cause swelling and a lot of pain on any movement. So if you pull it and you get those bones aligned, what have you done? You have eliminated the pain, you've eliminated muscle spasms until they can go to surgery, and they'll put a rod up the femur and that will be the fix. That bottom picture is called a Buck's traction. And that Buck's traction is just like an ace bandage wrapped around this boot. It pulls it, and over the bed, there are weights hanging. So nursing care of, well, always neurovascular signs, check pulses, right? That's always your first thing to check. But is that weight free hanging? And how many pounds of weight are on that? And we document this every shift. I mean, a lot of people come in and out of those rooms, so it could change, and we don't want to do that. So as I said, traction, it relieves the pain, it prevents deformities, and the biggest thing, it immobilizes it, so it releases those muscle spasms. This little girl has some tongs in her head. I've used that for a 16-year-old boy who slid into third base and his head hit the knee of a defender, and the stands heard a crack. He had a neck fracture. Usually the cervical spine is straight, right? At the level of C5, C6, it was angulated. You could see almost a triangle up there. And he had neurovascular deficits, both legs. So he needed to go to surgery, but we needed the swelling to go away. So we put tongs on to hold that neck straight. We put a cooling pad to decrease swelling. And we also, of course, gave him some sedation so he didn't feel all that cold, and steroids, anti-inflammatory. That kid did well. So some of the other tractions, bucks, which we've talked about. Russells can also be used for a femoral fracture. Bryant's traction, that's for the hips instead of that Pavlik harness that I told you about. And that puts the hip joint back where it has to do. And then let's say you had to have some surgical cervical spine surgery. They put them in these halos. Remember, when it's skeletal, it goes right into the bones with pins. So we need to do pin care, site care, and we need to be checking those sites for infection. Another thing we can do is, let's say a kid is born and one of the legs is shorter than the other, like this little girl here. We can put this external fixation device, it's called. It goes outside the leg and screws go into the bone. We can break the bone, pull it apart as the amount of inches we need, and the bone will form so that this child, we can make that leg longer. So these are another thing that we can do. Now, some kids are born without bones. They're born without legs, arms, fingers, all different things. I had a friend whose daughter was born without a fibula in her lower leg. And there was nothing they could do. They hadn't figured out anything better to do yet than a below the knee amputation. Let me tell you, I met that girl when she was 5 years old, and she met my children. And this little girl was running up and down the stairs, took her prosthesis off, was chasing my kids around the house with it. She didn't care. She was happy, and she was very mobile. That's all that mattered. Now, let's say it was a crush injury, infection, and we had to do an amputation. How do we treat an adult? We're going to look for phantom pain. We're going to check the wound. We're going to make sure that stump is going to be shaped in a manner we can put a prosthesis on. And of course, all the emotional care that goes on with that too. Now, children love to play sports. Many children do, and they're extremely competitive. So sometimes they can get overactive and they can cause themselves to be injured. One of the things that I always say to parents and to children, make sure they wear the proper equipment if they're going to play sports. Wear the helmet if they're going to go out and ride a bike. And if they're going to be on that hoverboard, make sure they have those wrist braces on so we protect the wrists, and even knee pads, with a helmet, because they are very dangerous. Overuse syndromes, some athletes, they train because they want to be the best, whether swimming, running, sports, it doesn't matter. But if you do the same thing over and over and over again, it can cause some damage. So you have to be careful. What is training and what's overtraining? Now, I've mentioned hip dysplasia. It's called developmental dysplasia of the hip. So you have your hip and you'll have your femur and the socket, and it should be right in there tight. And it moves, and that's the way it should be. Sometimes it's a little bit too high. Well, what would you see with these kids? Well, because that leg is higher, you're going to have a shorter leg, right? And if you look at their buttocks, because one's higher, they're going to be unequal, either buttocks or gluteal folds, they call them there. Another thing is, when you take your infant for your first visit, they always take the legs and move up and down. They're trying to hear that clicking sound, so they know it is that hip that's there. So you see that positive Ortolani and the positive Barlow testing. So your hip's out of joint, what are you going to do? It's a very simple thing. It is a harness. These children don't care if they have it on or not, doesn't bother them. It's on 23 hours a day. you only take it off to bathe the child. This Pavlik harness causes abduction of the hip. That's what you want. And that will put that hip socket back in the hip joint where it needs to go. Now, sometimes you have an older kid, and these older kids have to have the tendons are so tight, it will not go back in. You might have to remove them. And then those middle-aged kids, sometimes it's a spica cast, which is a permanent abduction with this cast, which goes from the waist and it goes down to the knees. And then in between, there's a bar that they carry them around with. Usually, just the Pavlik harness with the abduction works, but sometimes it goes to that spica. Rarely does it go further. Now, club foot. Now, club foot is when the feet and ankles are inwards, outwards, up, down. They're just not in the position they should be. Now, remember, it's 2 to 3 weeks they can heal, right? That's what we saw earlier in an earlier slide. You don't need to know all the different names of club feet, okay? So don't go bonkers on trying to remember that. Just know that kids have their feet. It's called club feet, a universal thing that can happen. So how are we going to fix it? Do they need surgery? Yeah, no. What they need is because everything's soft, malleable, tendons, all of these are all so pliable and so moldable, we do something called a Ponseti method. And that's what those casts are on that little baby down there. And every week, now remember, in 3 weeks they're healed. So every week we change the cast to put it in the position where it needs to go. And that will put those kids' feet where they need to go. These children will need to have it done as soon as they can, because remember, the younger they are, the way that they heal, right? We want that to happen. And then as they get older, they're going to need good follow-up to make sure that their feet, those club feet, are doing what they need. Sometimes they need to put on some sort of orthopedic shoes, but usually if they do the Ponseti method, get those feet where they need to go, they do really well. I actually saw a 1-month-old infant had it on and was put on Friday, and Saturday morning the mother was there, cast in one hand and the baby in the other. This kid got out of it, and how they did it, I don't know. They're Houdinis. That's all I can say. Osteogenesis imperfecta, or brittle bone disease. It's something that happens where can you imagine if we didn't know this and it comes through the birth canal? I'm sure clavicles would be broke, ribs would be broke. I mean, cranium could be broke. That's how brittle it is. So that's the most dangerous part of their life if we don't know. Many times we do today because of all of these advanced testings that we do. So we get this newborn, it's born safely. And now what do we do for them? Well, it's more supportive. There's no cure, nothing we can do. Our goal, give them the IV biphosphonate therapy, maybe some vitamins and calcium and vitamin Ds and all those things. But with all of these breaks that go on, what we want to try to do is keep them in a position that they're able to be mobile. We don't want them just laying in a bed with all of these broken disfigurements, okay? We want them to be able to get in a wheelchair. I'm telling you, Nicholas children, these children are in electric wheelchairs, and they're gonna go beep, 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 trying to get to the cafeteria before you. And they are so sweet. They're alert, okay? They're cognitively aware. They're not any mental deficiency. It's just all has to do with their bones break. Now, late calf birth disease is a disease that is a aseptic necrosis of the femoral head, which means there's not an infection. All of a sudden, the blood supply in that femoral head stops. No blood, what happens? It dies. What are we going to see in these children? Now, it is males, ages 4 to 8. one side, both sides, mostly one, but it starts with this, all of a sudden they're limping and it's soreness. And the parent is like, well, the kid doesn't play outside, hasn't fallen down, and he's been limping, complaining of pain, and he's been consistent. And you're like, okay, so what we do is we're going to do an x-ray, right? And we're probably going to give some Motrin to see if it helps. Well, usually Motrin will help because actually that's part of the treatment. And then we find this femoral head, sort of a fuzzy outline to it, and we know something is going on. So our goal is to protect the femoral head. So we don't have to do any sort of replacement surgeries or any of that. And we do that simply by bed rest. No weight bearing and giving NSAIDs for pain. They're also anti-inflammatory. Sometimes at home, they might put a Buck's traction to hold that leg straight, to hold the hip in position. And usually they recover completely and no ill effects. Now we're going to talk about 3 spinal things that can occur with different angles that go on. The first one is kyphosis. This is a humpback. You see this a lot in older people, right? But you can see it in children too. Lordosis, L lumbar. Lumbar is angled in, so it's an inward angulation of the lumbar spine. One of the signs of one of the muscular dystrophies we're going to talk about is called Duchenne muscular dystrophy. And one of the things that we see with it is lordosis. And sometimes that points us to the direction of how to get a diagnosis. Scoliosis, S, right? Scoliosis, an S-shaped spine. Now, the angles of the spine is what we look at when we're looking at what management do we do. Is it something that's gotten progressively worse in childhood? And it usually becomes more apparent at that pre-adolescent growth spurt. Remember, they grow 25% of their height during this 2-year period. So all of a sudden, you'll see that shoulder up, the hip up, and you might see a little limp going on because of this angulation. Well, they're going to be measuring the angle of that spine. So if this is less than 40 or 45 and it stays there, our treatment is going to be medical management. Now, what does this angle do? You're like, how does that make a difference? Well, that angle of spine pushes a lung over and compresses it. So you have less lung expansion. So it's respiratory. It bothers your lungs and breathing. So if it keeps getting higher, it's going to literally completely occlude that lung. So they have to do surgery. If they do surgery, they take and they put a rod, Harrington or Luque rods, and they connect it to the spine. And they try to make that spine as straight as they can. And these adolescents actually do very well with this surgery. Now, let's say it's 40 or 45, it's not moving, it's staying there. No problems with the lungs, what we can do, and most children get away with just bracing it. These are 3 pictures of a brace that we use for scoliosis. But with the brace, we're going to give them exercise to strengthen the muscles so that we can try to make that spine as straight as we possibly can. And my daughter's best friend since she was 4 had scoliosis, and she did the brace and the exercises, and she's pretty straight today. Now, osteomyelitis. Osteomyelitis is when the bone gets infected. You know, the most time I see osteomyelitis is usually a toe or a finger, because you could prick yourself, you don't realize the infection, it goes down into the bone, and now all of a sudden you get the streak up the arm, you get fevers, you take a CBC, your white counts are elevated, leukocytosis, and you know there's a problem. So we need to treat it. Now, osteomyelitis, you're going to do your labs, your cultures, you know, going to see that elevated white count. You may not see it in an x-ray, but physically you can see pain, swelling, redness, and streak going on there. So what do? Well, these children are going to be needing a central line, like a PICC line, a peripherally inserted central catheter, and they will be getting IV antibiotics for 3 weeks, 4 weeks, several months, depending on how resistant. Now, usually this is a staph infection. The big type of medication we use for staph is vancomycin, right? Or amikacin or gentamicin. You hear the sin on the end? These are all aminoglucosides. Aminoglucosides, side effects, hearing loss, kidney damage. So they have to monitor peaks, troughs, and monitor liver and hepatic function to make sure that it's not going to affect that. And, being on those 3 to 4 weeks, you can have side effects, so to be aware of it. Now, these kids should be immobilizing whatever the limb is. They usually, because the PICC line, are not going to school, they're staying home. And we need to give them good nutrition. And you're talking bone and muscle, you're thinking of good protein. So high protein diet, because that helps with the healing. And again, these children are immobile, they're at home. Remember, they're going to need some encouragement, that the parents need to know, hey, do something to keep your kid happy. Maybe let him play a game, for a month while he's on this, or, buy him a book that he likes, or whatever the kid's into, to help him pass that month. Now, we've talked about cancers. This is another one. Ewingsarcoma could be scapula, could be the jaw. We treat it just like the other cancers we talked about: radiation, chemo, and surgery. And it could come into any bone. So the prognosis, of course, with any cancer, bone cancer, any cancer, is if it's metastasized. So hopefully we got it before it metastasized, because the outcomes are going to be better. Now, JIA. Children do get rheumatoid arthritis or juvenile idiopathic arthritis. We usually see it in your toddlers, ages 1 to 3. And many times, they get up in the morning, they're moving, they don't see it at first, but then they start complaining because it hurts. And, we know that it could affect a knee, an elbow, a finger, a thumb, an ankle, a toe, and they start complaining. So the classic signs and symptoms are morning stiffness. Now, I've told you, I have rheumatoid arthritis. In the morning, I look like an old lady trying to walk. I mean, I have to try to sit there and stretch and move and get my shoulders, my back, my hips moving. And with that, walking, so I sort of shuffle in the morning until I get moving, and with a limp, for sure, a limp. You will see their joint swelling when it gets quite, like a flare occurring. And then if we're not going to treat these children, you can get a lot of disfigurements. I mean, you've seen pictures of the older people and their hands and stuff. I mean, I got a crooked little finger here, but I think it's because of the mouse that I use for the computer all the time. But I don't know, whatever. It's okay. If it's just a finger, I don't care. But the other thing is that I've learned teaching you all is uveitis, which is an inflammation in the eye, which could cause blindness. So these children need to go ophthalmology once a year. The problem with this juvenile idiopathic or rheumatoid arthritis, it's always so hard to diagnose. With me, and I know a little bit about things, it took me 8 years. Okay, they didn't know what was going on. They're getting better tests out today. It was finally a physician said, there's a test called a CCCP, which I'd have special approval, insurance, you know how that goes, and then do a rheumatoid factor with it. Now, a CCCP test should have the high normal as 50. I was greater than 250. And then, of course, my RA was positive. So the doctor said, I should have listened to you. You were right. You're not fibromyalgia. And I'm like, I knew something was wrong. You're not listening to me. And, that's somebody who's intelligent and who has decent insurance. Can you imagine these children trying to fight, parents trying to fight, getting them treatment? Now, when we start seeing flares and we start seeing them in pain, what we're going to see is all your inflammatory factors are going to be elevated. Your SED rate, your C-reactive proteins, those are going to be really elevated. Your white cells are going to be up. And then your ANA can be yes or no. And then your rheumatoid factor, I've seen mine, yes and no. So it could be either or. So how do we treat this? Well, there's no cure. It's trying to keep those flares at a minimum. So to preserve the function, save the joints, and keep the kid home and keep them active and normal, right? They put them on NSAIDs for pain, anti-inflammatory, it works. Unfortunately, I'm allergic to NSAIDs, so I have to do Tylenol, but it's okay. Tylenol actually works on me. And then they're going to put them on some sort of anti-rheumatic, Humira, Enbrel, Cimzia, one of those. And if that don't work, infusions. And they do it in combination with methotrexate, which could be an injection or it could be some pills. And then when they're really severely in pain, corticosteroids, but they don't keep them on all the time, only when they need it. So physical therapy, occupational therapy for young kids, keep the pain good, keep them healthy, eating well. And then if they hurt, heat and exercise. Now, I don't like heat. Heat makes me worse. So I use cold. So I'm telling you, it's either cold or heat, depending on what they like. Now, rheumatoid or idiopathic arthritis, it's the body attacking its own joints. Lupus is when the body is attacking organs, any organ. Skin is an organ too. That's why you get those red cheeks that are going on. It's usually in girls, women, that 10 to 19 age, so your adolescence type thing. And it could be the beginning of, puberty, or it could be something in the environment, infection. But here, South Florida, exposure to sunlight. So that's one of the other things. We all love going to the beach down here, going to the pools. I mean, could be part of it. So what do you see? Well, of course, that rash that you will see, and then nausea and vomiting, diarrhea, pain, and it could be joint pain, like rheumatoid arthritis sort of looking. But when it gets to the point where you're getting forgetful, you're not remembering things, your orientation is not where it should be, then it could go into seizures, paralysis, etc. And then, of course, it affects the heart, pleurisy, affects the kidneys, you'll see proteinuria. So what is our goal? Well, many of these children will be on low-dose steroids. It usually is what help, and sometimes they add other medications depending, what works or not. It depends on the child. And then, of course, monitoring the amount of sun they get and sunscreens to put them on, just on a daily basis, just going out, waiting for the bus, they're in the sun, coming home, they're waiting for, they're out there in the sun, or going out for PE, making sure the children know to take care of themselves. So Kirsten, 10 years old, sustained a fracture in the epiphyseal plate of her right fibula when she fell out of a tree. When discussing this injury with her parents, the nurse should consider that what? What's an epiphyseal plate?
B.
Absolutely. It is that growth plate. All right. So neuromuscular, muscular dysfunction, but neuromuscular, it means the brain can't make the muscles work the way you want. Let's think of it that way. So the brain, there's some sort of disconnect. We think of CP, cerebral palsy, don't we? These are those children that have these weird spastic movements. They can't feed themselves. They can't move their arms, the legs the way they should. It is something that happens to many children. It's the most common permanent physical disability in childhood. And cerebral palsy could be caused by a couple things. Could be something in the brain wasn't made right. It could be this occlusion, which means hypoxic, anoxic episode. I mean, I've seen children that couldn't get through the birth canal. They pushed it back, did a C-section, but they already had hypoxia, anoxic episode, and they end up with cerebral palsy because of this, just at birth. Or it could be that premature infant. Remember, their brains are fragile, so they get these intraventricular hemorrhages. So these are many causes that you'll see. I'm sure there's a lot more, but these are the ones we mentioned. So what do we do when we're trying to evaluate them? Well, if a child was premature, they're going to be watched closely for the first year of life. Seeing, are they making those milestones? Are they fine motor, gross motor skills? Are they turning over, lifting their heads, eating correctly? All of those things will point to they're slow, something's going on, and that could get to the diagnosis of cerebral palsy. The most common of all the cerebral palsies is what we call spastic cerebral palsy. Now, some of you who had went to the PPAC that I used to do clinicals at, there's a little boy there called Jonathan in the toddler room. He's in a wheelchair. And this little kid is nonverbal cerebral palsy. And he literally, when he sees me, or he used to see me, his smile would go ear to ear, his white teeth would hang out, and he would start shaking so spastically because he knew I was going to run up and give him a big hug and a big kiss. And I'd sit there and talk to him. And that was the light of his day. And he's nonverbal. He does have this little pad he can talk with, and he would. And it was great. Years ago, we didn't do anything with cerebral palsy. I was working with this foundation as a teenager. So I'm talking 50 years ago. I mean, that's how, I'm sorry, I'm old, but a long time ago. What did we do at cerebral palsy? Well, we basically fed them, got them out of bed. They watched videos, grooming. It wasn't teaching. Today, Jonathan is learning how to do shapes and do colors. And that's far beyond anybody ever thought that he would get to. And actually, he's pretty smart as a kid when he wants to, because he can be stubborn. But he actually does know all of these things. I have to go back over there and see this kid now that COVID has calmed down, because that place has tried to hire me about 100 times. They keep calling me. When you have a kid with cerebral palsy, another kid, it is a great thing to do that metabolic genetic testing to make sure what was the cause of cerebral palsy. So again, what do you see? That gross fine motor is going to be lower. That motor is going to be not as able to control. And of course, that abnormal postures, reflexes, and some can walk, some can't, and some we can teach to walk. Our goal is to make sure that they can get up and move, whether it's in a walker, whether it's in a wheelchair. This little boy has got those little splints on his ankles so that he can pedal a bike and get around. And he's happy because he's mobile, right? Keep them with other kids, get them social, and educate them to their level, and then keep going, try some more. Ankle foot bracelets are done. Sometimes we do surgeries for those spastic sort of things. Pharmacological, I mean, botulism is used, right? Botox. And I seen Jonathan was using carbidopa levodopa, which is used for Parkinson's, which is spastic, right? Which is what he had. And actually it has helped. And the teeth really have to be maintained. A lot of them do have seizures. And we know things like the phenytoin or dilantin causes that hyperplasia of the gums, right? So making sure their teeth are good. Prognosis, you have some very mild and you have some severe. The mild ones can be trained just like the mild downs. And they can do things like being your cashier, doing your bagging at the grocery store, and you'll see them there. They're doing something and they feel good about it. So prognosis depends on how severe. And as a parent, making sure that as a nurse teaching the parents, make sure they have everything they need at home. make sure that they have the equipment and that they have all the available therapies that they do need. Now, neural tube deficit. Last week, we talked about midline closures in the front, gastroschisis, the stomach hanging out, right? We also talked about the bladder exstrophy, that hanging out. Well, at the low back, at the lumbar area, the spinal cord and meninges bulge out, and it stretches the nerves as it goes, which means the lower extremities could have minimal or no feeling or movement at all because of that stretching out, okay? Their brains are perfect though. Their brains are, they're smart children. So again, what do? Number one, protect tissue integrity on that back, okay? They're gonna lay on their bellies because you can't lay them on their back. Now, I had one of these kids, Manuel Louis was his name, and the mother was crying. And it wasn't my kid, but it was in the room where my children assigned to was. And there was no nurse there. And I'm like, oh, I can't let this mother cry alone. So I went up to her and I said, Mom, what's the matter? And she goes, you know, the doctor's telling me they don't know if he's going to make it. And I'm just so worried. I says, Mom, look at this child's face. He's beautiful. He's perfect. I says, he's probably going to need some help. He's going to have some decreased sensation in his lower legs. But I said, you look like a mother that's going to give your child every opportunity. Okay, the end of the story. 14, okay, no, there's more of it. So I made her sit down in a chair. I wrapped him up in a blanket and put the kid in her arms. And she just sat there and cried and rocked her little baby. And she was so happy. And when she left that night, she told me, thank you. 14 years later, she saw me in the emergency room. And Manuel Louis was in a wheelchair next to her. And she told the registration clerk, she goes, I want her. I want her. Tell her to come here. So I went out and she showed me a keychain with a picture of me holding Manuel Louis when he was a newborn. She said, I've been looking for you for 14 years to thank you. Look at him. He just went to his 8th grade prom. He's in regular school. He's getting A's and B's. And thank you. And he wanted to hug me. Said, thank you for taking care of my mom. This is differences you can make by 5 minutes of your time. So why do these things happen? Well, they don't know. It's in the very beginning of the development in, intrautero. It could be obesity, diabetes, low B12. They're not really sure. We know that folic acid has a lot to do with this. You learned that in pharmacology. So you got the kid born, he's got this meninges and spinal cord on his back. You're protecting it, the skin integrity and an infection. Now, what else do you need to look for? Immediately, these kids are going to be under latex allergy. They're going to need multiple surgeries. This child also may not have any feeling from his belly button down. The nerves are stretched, which means he doesn't know when he has to urinate. He doesn't know when he needs to move his bowels. So you really need to watch urinary output and you need to watch bowel control. Another thing that could happen is because that tube was interrupted, sometimes the cerebral spinal fluid can't go up and down good. So they might need a ventricular peritoneal shunt. Okay. But they breathe fine and their heads, let me tell you, Manuel Louis was absolutely perfect. As I said, folic acid. Now, everybody knows they're going to be pregnant a month before they get pregnant. So make sure you take folic acid. I never did. I didn't know. I got pregnant. Now, muscular dystrophies. We have Werdig-Hoffman. It's also called floppy infant. So this is their muscles just start to, they don't work and it progressively gets worse. That's muscular atrophy, okay? Or dystrophy. So these children are born, look fine, because no kid at birth can lift their head up, right? But at 2 months old, they're not lifting their head up, not trying to turn, we know there's a problem. So And remember, it's progressive. So usually they die before they're 2 years old. They'll never move. They're just these children that are just floppy. They're weak, and their cry is weak, and it's a terrible outcome. But that's one spinal dystrophy or atrophy. Now, Duchenne muscular dystrophy is the one your Hesse, your NCLEX loves to talk about. And this is something that we see is called a pseudo-hypertrophic muscular disease. This is a kid that mom's X-linked recessive trait was given to the child, and these are boys, ages 3 to 7. So before that, they're looking fine. They might have large, muscles in their arms, in their calves. And all of a sudden, they start to shuffle, waddle, gait. You start seeing them falling, and you're like, something's not right. It gets progressively, the muscles aren't working. So they get them in, and they have that lordosis, like I said. So that's part of this one here. So what they do to try to diagnose this with all of these things is they do what we call an electromyography. And it's a simple test. They either use little electrodes or sometimes little needles, and kids usually electrodes because it's less threatening. And the machine gives a little burst of electricity, and the muscle spasms, so it works. Now, how quickly it responds and how much it responds shows you if the muscle and how it's working. Now, when you have somebody making your muscle spasm like that, make sure when that child goes back to the floor, he gets some Tylenol or Motrin, because he's going to have a lot of muscle pain afterwards. But of course, it's temporary. These children are going to have some mental impairment. These children are usually overweight because they can't move as well. These kids will need really aggressive therapy, but they usually will die in your teenagers due to failure of heart and lungs, their muscles, the diaphragm. So if a parent wants to have another child and they know their boy has Duchenne's, they really need to go to genetic counseling, because remember, mom gave it, and that's why the boy has it. So keeping them mobile, keeping them moving, range of motions, all those therapies will give them the best life up to where they can. Now, Guillain-Barré, have you heard about that in MedSearch 2 yet? Okay, Guillain-Barré, good, thank you. Guillain-Barré is also called infectious polyneuritis. So basically, about 3-4 weeks after an upper respiratory infection, so it's viral. This is not bacterial, it's viral. And the nerves get attacked. And it starts with the feet, and then it moves upwards. It's ascending, feet upwards. And the nerves are made numb or partial paralysis going on. So these children, you're going to see them, your muscles hurt, they're numb, they're falling down, you can't control them. And then it moves up, and then you see a kid who's already potty trained become incontinent, become constipated, and then it goes up and it hits the phrenic nerve, and you stop breathing. So nursing priority, you need to monitor respirations. This is something that happens, and it usually mind boggles the physician. What is going on here? Normal, healthy kid, had a cold, and now all of a sudden falling down, this and this, and now they can't breathe. How do we treat these children? Well, they're not breathing. They need to be on a ventilator. So they're intubated, maybe even get a tracheostomy if it stays longer. We treat them with intravenous immunoglobulins. That for sure we're going to be treating them with. Sometimes steroids, sometimes plasmapheresis, but IVIG, intravenous immunoglobulins, is given. And it basically tries to boost that immune system. So I actually had, it was a supervisor, a nurse, she was like 20 something, ended up with Guillain-Barré. And they diagnosed her and she got bad at the hospital. And she went to the ER and they brought her up to the ICU. She ended up intubated there for over a month. Now, when your phrenic nerve is paralyzed, there's no spontaneous respirations. And then all of a sudden, you saw that ventilator get an extra breath. So you know that, oh, she's taking a breath. And then she took more breaths. And then we decreased the ventilator and she would breathe more and more. And then it would go descending back down and go away. Now, this girl, even children act the same way. They're going to need therapies when they're done because there's going to be some muscle wasting, even with range of motion and physical therapy and all of that. But they can come back and they can do really well with this. Tetanus, step on a rusty nail, right? Well, the problem with tetanus, the symptoms are all upper neck, where the muscles get tight, squeeze the airway, you can't breathe, you can't talk, you can't eat, okay? And it is, can you imagine the biggest muscle cramp you've ever had? Multiply it by 10. That's what this feels like. So these children end up on a ventilator because they can't breathe. And they put them on big medication for muscle paralysis. The medicines that they would use to put you under for anesthesia to do surgery, they knock you out because, you know, the pain and because we have to ventilate, okay? We give tetanus toxoid, okay? Tetanus toxoid is given and we just do monitor the respirations, keep sedation, keep the paralysis going on, and then we'll be cleaning whatever they stepped on, their finger or wherever this tetanus came from. Now, how often should you get a tetanus shot today? It's 10 years now. And they're also giving the diphtheria immunization with it. And that started about 6 or 7 years ago. I've seen it every 3 years, every 5 years. Now they're saying every 10. But if we get something dirty or an animal bite, anything, they're going to give you a booster. Botulism. Have you ever been told to have some honey or some corn syrup for an infant who was constipated? You can't, because we don't know when honey or corn syrup was sterilized. Is it infected? And it could cause botulism. And the outcome is so similar to tetanus. You'll start out with that weakness and speech and vomiting, and again, respiratory paralysis. So no more honey, no more Karo syrup, okay? Don't do it. Tell everybody no. And again, IV immunoglobulins for that botulism and just support them. And hopefully the kid comes back. Spinal cord injuries. Now, you heard me mention my little boy sliding into third base and that angulation of that C5-6 fracture. That was a sports injury, but it could be due to anything. How about a birth? We pull the head and the neck, right? It could cause some spinal cord injuries. You know, we don't know. Or car crash, your head back and forth, coup to coup droit, or hyperflexion, you know, of the neck. Our goal as a nurse, now I was the primary nurse when that kid came in, where he had a collar on, he was on a board, he was taped down, his right leg was completely paralyzed, his left leg, he could move his toes a little bit, okay? My goal, and the only thing I cared about, was keeping that neck immobile. Because if that was angulated, if he moved, he would be totally paralyzed for life. And that wasn't my goal for him. So that is what I did. I got him to the MRI. We took it. We found out exactly what was going on. We brought him up to the ICU. I even got him on the bed. We put the tongs on, got him on a cool pad, got him some good sedation so he could rest through it. Went to surgery the next day. And 2 weeks later, I went to see him. Right leg completely moving and left leg had some slight numbness in it. He was going to rehab. He came 1 year later to see me and he was perfect because of immobilization. A progressive infantile spinal muscular atrophy, and the most common paralytic form of floppy infant syndrome. I won't let you suffer.
D.
It's C. Wording Hoffman. It's okay. I won't let you suffer. The one you need to know is Duchenne's, and I've told you that. So those are my stories for tonight. Let's go to our coots. Who wants to win? Oh, there you go. So remember, no honey, no Karo syrup. I think you got the point, huh? I'm not pointing fingers, but I've heard it before. I've heard it repeatedly. I'm like, no, don't do it. I mean, the best honey is from the trucks that we see on side of the street, and it looks like it's good stuff. Or down Chrome Avenue, it's great honey. No, don't do it. Not to babies. You can have it, not babies. They don't have an immune system. And I have it with my lemon ginger tea. It's perfect. A little bit of honey, it's perfect. Give me 1 second. Okay, let's go. My grandson's here and daughter came in and started screaming. Poor little kid. I spoil him, you know that. I'll multi-select. What is priority for a nurse to assess following a cast application? You know, and it's not only your priority to check, it's your priority to teach the child if they're old enough and parents what to look for. Because remember, these swelling could cause compartmental syndromes, right? So all of them. And remember, paralysis is movement, okay? It's another word for movement. So P. And it's paresthesia, which is sensation. So all the P's, there's 6 of them. What should the nurse monitor after a soft tissue injury? You got a bruise. Oh, it's just a little bruise. No biggie, right? Always check neurovascular signs. It may be occluding, some sort of big vessel, and then you'll be in more problems. A fracture that penetrates the skin is called. Open or compound. Remember, if that bone sticks out the skin, you always consider that it's infected. So what is the priority? Nursing care of a child with a compound fracture. Could be a finger, could be a toe, could be an ankle, could be a wrist, could be anything. IV antibiotics. It's been exposed to the air. It's infected. It's needing IV antibiotics now to prevent that infection, preventing osteomyelitis. What is priority nursing care for a child who fell off of a second floor balcony? I've seen a 2-year-old fall off a second floor balcony. And I'm going to tell you, the girl was lucky. She fell on grass, not on a cement walkway. She was very lucky, and she actually did very well. Of course, she was admitted for monitoring. But again, any fall, you suspect spinal injury, immobilization, your priority. And if you're in charge, nobody touches that kid unless you say so. And they're going to move on your count, nobody else's count. Principles of managing soft tissue injury include: you have a sprain, you have a strain. What do you do? So that's going to be your RICE. Rest, ice, compress, and elevate. Like me, float right up in the air right away to prevent swelling, because you can feel it start to swell. Epiphyseal plate fractures in children may do what? What is an epiphyseal plate? It's a big word. Remember, it's right where those bones meet there, that they're just not right. So epiphyseal plate is that growth plate. And if we do not make sure that the surgery get it correct, that it will disrupt the growth of bones or cause a disfigurement. And we don't want to do that. What findings for a patient in skeletal traction indicate peripheral neurovascular impairment? I mean, this is the biggest thing with fractures and sprains and strains. It's making sure that your blood is flowing the way it should. Because remember, there's swelling. It could include a lot of different things underneath there. So no pulse, we got a problem. And we're going to call the doctor right away. I'll multi-select. How should the nurse care for a skeletal traction for a child with a fractured femur? Now, femurs can be either skin traction, which is the bucks, or skeletal, which is a pin called a Steinman pin. It does the same thing. Today, they're using more of skin traction. And it pulls those bones, so you don't have all that pain there, right? Make sure you document the weight of that traction every shift, so you're looking at it, because people come and remove those things. Crazier things happen. And of course, never ever take the weights off, because you're going to create that bone to move, pain's going to occur, and you want it just to hang there really nicely. When caring for a 9-year-old in bucks traction, what action by the nurse is correct? We're just going to make sure that the capillary refill is there, pulses are there, right? We're not going to put the weights on the table. That's going to take the weight off. No. Raise or lower the bed? No. Maybe the head of the bed. And we don't want the sibling to sit there, because it can cause pain for that poor kid. I'll multi-select. Which assessment indicates an infant has developmental dysplasia of the hip? So when you see those folds, gluteal folds, butt cheeks, leg folds, one is going to be up more than the other. Remember, you're going to have a shorter leg there. More reflex is a startle reflex on infants. Positive ortolani, you're going to hear that clicking going on. And positive Babinski just has to do with checking a reflex of the bottom of the foot. It's nothing to do with your hip. What position do you put the legs of an infant with hip dysplasia? We're going to use that Pavlik harness, right? But what position does it use? What do you want? What will really ensure that that hip goes back where it needs to go? It's called abduction, okay? Abduction, Pavlik harness is what your goal is, and then it will go back into where it has to go. What statement by parents indicate more teaching regarding the 2-year-old infant, 2-month-old infant with club foot? So you got this new baby, 2 months old, and I mean, these are really severe club feet. How are we going? What parent is telling me wrong information? I mean, 3 are right and 1 is wrong. So treatment needs to be started right away. Absolutely. Follow-up care until they're grown. Absolutely. They need to go to the clinic every week. 1 month is way too long. Remember, they can heal in 2 or 3 weeks. And we need to keep moving that so we get those feet where they need to go. I'll multi-select. Osteogenesis Imperfecta. You know, there actually has been some cases of parents with children with undiagnosed osteogenesis imperfecta that they thought it was child abuse until they finally diagnosed them with osteogenesis imperfecta. So that's something that has happened, but it is nothing to do with it. The bones are crooked, it's brittle bones, and you're never going to do aggressive physical therapy. Just touching these children, the bones break. So gentle, if anything. What is the pathologic cause of leg calf birth disease? So leg calf birth is that hip socket becomes infected for who knows because of no blood. But there's nothing in there that's causing an infection. It's like no blood, so it dies. So how do we treat these things? Well, NSAIDs, bed rest, and maybe traction. So it's an ischemic aseptic necrosis of that femoral head. And once treatment and the bed rest, it actually is okay if we catch it good enough. Kyphosis, what is it? Kyphosis is the thoracic spine or the upper back, and it's also called a humpback. Lordosis is described as and remember, this is one of the signs that you might see with a child with Duchenne muscular dystrophy. It's that inward curvature of lumbar spine. Remember, L lumbar, L lordosis. Scoliosis. And remember, this is that S-shaped curvature, and we're concerned when those angles get more than 40 or 45%. Adolescents with scoliosis that have up to a 45% curvature of the spine would need to do what? This is up to. This is not over. This is under 45%. So if it's under 45%, it's not progressing. These children wear brace 23 hours a day, and they also do strengthening exercises, physical therapy for their muscles in their back and their abdomen. What is osteomyelitis? So osteomyelitis is an infection of the bone. And of course, we know bone infections are very serious and create, child to be very sick, with fevers, etc. Goals of JIA include juvenile idiopathic arthritis. And again, does it matter if it's a kid or an adult? The goals are really the same, isn't it? Reduce the joint pain and the swelling, keep them moving, and treat them like children. A multi-select. What might you anticipate for a child diagnosed with JIA? Like, what would you see in an assessment? So you might see joint disfigurement if it goes on a while, difficulty walking, morning stiffness, that uveitis, right? The redness in the eye. Facial rash is your lupus. It's not JIA. A multi-select. What can help a child with lupus erythematosus prevent exacerbations? So when you have a child with lupus, have them wear sunscreen, have them decrease the amount of sunlight, and then anything procedures they're doing, have some prophylactic antibiotics. What organs can lupus affect? Any organ, all of the organs. What is cerebral palsy? So cerebral palsy has a thing where the brain and the muscles, there's a disconnect, and it's going to affect the body movement and muscle coordination. Myelomeningocele. So when you have a myelomeningocele in the low back, it doesn't close, just like what we discussed last week, the gastroschisis and the bladder exstrophy. But what it is the spinal cord and the meninges. Remember, if it's pulled out there, there's going to be some nerve damage to the lower extremities. Infants with myelomeningocele demonstrate what? Remember, those nerves have been stretched. So motor and sensory impairment, and your concerns is urinary retention and also constipation. Myelomeningocele have decreased motor and sensations of the lower extremities. The nurse should monitor closely what? So again, we're going to worry about that urinary retention. That is the big thing here. I mean, of course, we're going to monitor skin integrity of the area and infection, but we're also going to be monitoring that bladder, making sure it doesn't overfill. They don't feel it. They have no nerves there. A key feature of Duchenne muscular dystrophy is it is progressive muscular wastage. Usually boys, ages 3 to 7, you'll start to see it at age 3, where they've got these hypertrophic muscles in their arms and in their calves, and all of a sudden they're falling. You might see that lordosis, and then of course that goes on to doing examinations, doing an EMG and finding out what's going on. What is one of those procedures that a child with possible Duchenne's may need to diagnose this condition? And it's that EMG. Very good. Muscle biopsy doesn't do anything here. How is Duchenne muscular dystrophy inherited? Who gives it to the child? And that's why we need to do genetics in case they want to have more children. And it's mom, X-linked recessive. In caring for a patient with Guillain-Barré, the priority concern is what? Remember, Guillain-Barré is something from a virus, so it's not infectious. It's just something about those nerves, but it goes up, hits the phrenic nerve, and then they can't breathe. So maintaining an airway is always priority with Guillain-Barré. For patients suffering with Guillain-Barré, they would complain of weakness that was what? It's what we call ascending. And what I mean by that, it goes from the feet and works up. That's ascending. And then when it gets better, it's descending. So then the nerves going down start to work as it goes down, okay? Ascending is up, descending is when they get better. I'll multi-select. Treatment for Guillain-Barré include what? So treatment is going to be IVIG and respiratory support. It is not an infection. Antibiotics are not going to do anything. IVIG is intravenous immunoglobulins. It boosts that immune system because it's a viral something, maybe. And then, of course, we're going to maintain the lungs working. Usually, they're on a ventilator. What type of cerebral palsy causes hypertonicity and poor fine motor skills? So when we talk about cerebral palsy, that's hypertonicity and poor fine motor skills, we're talking about spastic cerebral palsy. I mean, that's like my little Jonathan, very tight and spastic, that hypertonicity. What priority action should a nurse take to a patient with a suspected spinal cord injury? Make sure you keep that spine immobile, okay? Very important. You don't want to give that child more damage than you can. And, you know, these kids can get, paralyzed. We don't want to do that. You should get a tetanus shot every how many years? It's every 10 years. Good job. And they do it with the diphtheria now, as I said. What is a symptom of tetanus? Lockjaw. Remember, everything tightens in the airway and it causes airway obstruction, and they're going to need a ventilator also, and something to relieve that pain, those muscle relaxants. And of course, we're going to give those tetanus toxoids, immunoglobulins for them too. And last question. Most common cause of spinal cord injuries are what? And it's motor vehicles, always. That's always going to be number one. Driving and, of course, sports. Good job, guys. Let's see how we did today. Number 3. Good I sees. Whoop, 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 whoop. Number 2, Yanni, of course. And number 1, JDY. And Jill and Meg. Good job, guys. What I want you to do, please sign your attendance attestations. Make sure you get them done. Remember your pediatric assessment assignments. If it is less than 90, go look why. Make sure you go back, do what I tell you to do, and then I will increase the grade. Just let me know that you've done it. So Christian, he's saying hello to you. That was his boo-boo, his big on his head this time. Say hello.